Valium, Ativan, Soma, the stimulants, Ritalin, Adderall, Concerta, Vyvanse. There's big money. When I was a medical student in the early 80s, I did a lot of my rotations in Dayton, Ohio, and it was inner city hospital, Grandview Hospital. At that time, okay, so mid-1980s, Ritalin was selling for 35 bucks a pill. I mean, right outside the emergency department. So, and there is still big business. You know, college students have a tendency to abuse that stuff. You know, they get it from their friends, especially during finals. And you can see probably painkillers are the biggest ones, and I think we have to be very, very careful. And they're sort of easy to to get. So, drug-seeking behavior is the intent to obtain a prescription under false pretenses. It's a felony in order to obtain medical care under false pretenses, and we do have people arrested. You know, and people, they come to the emergency department with no ID. You know, and I lost my prescription for VICO. It's like, you think I just started practice yesterday, and you see this sort of stuff all the time. And there's been a lot of attention, Ritalin, OxyContin underground, and we know about that. They're probably some of the most, highly abused and probably the biggest street value. I know in Stevens Point, Vicodin at, I think at Walmart, it's about 25 cents. It's in Stevens Point, they're selling it for 5 to 10 bucks a pop. So, pretty good markup, okay? So, I think we got into some trouble. I think it was in 2000. We started to address pain, and it's always amazing, especially all these work comp people. They always go, well, my pain today is a 6 out of 10, And I see people, I see some of these old farmers come in where, farmers are tough. They work the land, they're in business for themselves. I was thinking of this guy. He was a potato farmer. He broke his ankle. He had a trimalleolar fracture, but it was the end of harvest. So he never took his boot off for 3 days so he could finish harvesting. He walked into the emergency department. He's, okay, doc, let's take her off because I know she's broken. The guy, he worked for 3 days because I couldn't afford to not finish the harvest. So, pain certainly is relative. There's and I don't know if she's still in practice, Dr. June Dahl. She was with the state of Wisconsin, and she went around the state saying we were inappropriately treating people and we needed to really address this. And there's no question. I mean, you come in with a kidney stone, you come in, with a bone sticking out, we're going to treat you. But, a lot of this stuff is just nebulous, and it doesn't make a lot of sense. I think part of the problem with a lot of these folks, it's my opinion, I don't have any sound, hard facts, but 80% of all the people who are seeking, drugs are seeking them to sell because it's a good business. There's 20% of these folks are, has been iatrogenically induced, unfortunately, because it's easier. These people are, they're a pain, and they keep calling up, and it's easier to write a prescription for 20 or 30 more Vicodin, and all of a sudden these people truly are addicted. And, as physicians, I think we've done a disservice for not appropriately seeing them and addressing them. Codeine, useless medication, I haven't prescribed it in over 20 years, causes constipation, is no better than ibuprofen, especially Tylenol with codeine. It just doesn't have any good clinical efficacy. I guess as an emergency physician, I know how to treat pain. I do a good job of treating pain. When you've got pain, I can get rid of your pain, okay? Codeine is not one of them, all right? The synthetic opioids, Norco, Lortab, Vicodin, Lorcet, it's either oxycodone, hydrocodone, you probably heard those. Certainly good medications, then they've added, glycoprofen, very expensive, take a little generic Vicodin and take the cheap ibuprofen, it's all the same. There's some of the other medications, Percodan, Percocet, Dilaudid. I use a lot of Dilaudid in the emergency department. OxyContin is mainly for your own edification. You probably, just so if you see these terms, especially in claims, It's certainly used in chronic pain management, and there are people, you're a cancer patient, pull up the semi, we'll give you as much narcotics as you want, because we don't want you to suffer. I think that's reasonable, okay? There are some chronic pain conditions, some severe arthritic, but those are, it's certainly used in that. It does give you a buzz. I have never taken a narcotic personally, so I don't know. People who don't take them say that, boy, they don't really like the feel of it. You knew about Rush Limbaugh. I mean, that, Rush Limbaugh, Brett Favre. I mean, I think in 2000 we started to really look at those issues. The synthetic opioids, methadone, Demerol. I haven't prescribed Demerol in years. Fentanyl is another one that's certainly very good. Suboxone is used for kind of long-term chronic management. You have to have a special license. Like methadone is a Schedule 1. I purposely, I can get it, but I do not have on my DEA license. I don't have a Schedule 1 because there is a clinic in Wausau. So many times these people, I can't get a ride. My dog ate my methadone, my prescription, and they come to the emergency department. Oh, I'd love to help you, but I'm not licensed to prescribe it. And they don't, and the methadone clinic, and it's always after hours, naturally, where their car breaks down or whatever. So, I just have purposely made that decision not to do that. I think, something that was really, really sad. There was an article in the Milwaukee Journal a few years ago. In Portage County alone, we've had, I think, a half dozen to a dozen deaths secondary to prescription drug overdose. There was a kid actually in my neighborhood. My son knew him. My son didn't know him that well. He didn't go to school with him. He went to a different school. Seemed like a nice kid, but they were doing farm parties, PHARM parties, and you steal all your parents' medications, okay? And your parents are gone. And then you take them in a bowl, and then you go to a party, and you take a handful and see what happens. Well, unfortunately, this kid woke up dead. Sad situation, sad situation. That really opened the eyes of a lot of people, in our area, to protect your medications. And this kid was 14, 15 years of age. And we do it, we intervene, we raise concern. We do care conferences. I always have another sad case. Fairly well-known family. Mother was an enabler. The daughter had all sorts of psych problems. The father was fairly well-known, involved in athletics, so he was kind of a tough guy. This poor gal, everything hurt, kept coming in the emergency department. And I was chairman of the Department of Emergency Medicine at that time. Had the care conference with the family. The mother was enabling, saying we weren't listening to your daughter's concerns and wanted more narcotics. And the dad was a little bit, he was probably just supportive of the wife to a certain degree, a little bit withdrawn. This gal, unfortunately, had a fentanyl patch, you put them on your back. She died by sucking on the fentanyl patch. She aspirated it, and it covered her windpipe, her trachea. And she was found dead with the fentanyl patch over her windpipe, and she suffocated. And it was one of those things. You could see it was going to happen. I hate to say it, told you so. The family certainly felt terrible, but they didn't appropriately intervene. So we're certainly very aggressive with this, and I've just always had a passion for this. When I came to the emergency department 25 years ago, we used to treat everybody migraines with narcotics, and I started to do research and said, this just doesn't seem right. And there was a train of people. I could probably to this day probably remember 50 people that would come into the emergency department. Their docs would call it in, give them some Demerol and Vistarel, and send them out. They'd be back. They'd come in 4 hours later. They'd be back, and this would go on for days. A lot of people got addicted to this stuff. Well, I started to do the research and found that with migraine headaches, it's the wrong thing to do. You get rebound. So 20 years ago or longer, we stopped giving narcotics to migraines because it's bad. And I'm still seeing it today. There are some docs doing it, and it's just not the right thing to do. We use the anti-nauseants. If someone truly has a migraine, the anti-nauseants do work. Give a little bit of Decadron, a little IV steroids, some oxygen. I tell people, and people from out of town will come and say, I need my shot of Demerol or Dilaudid for my a migraine. Well, it's not happening. Well, my doc always gives it. Okay, not me. Well, call my doc up. He'll tell you to give it. I'm not calling your doc up. You know, you're here. I'm happy. You will leave here. I promise you, you'll leave here without a headache. Well, then, you know, if it's a little suspect, they many times just leave. But it's been very successful. Like I said, the anti-nauseants, you know, the steroids, the antipsychotics, Thorazine is an end-all that works very well. And people leave without a headache. I guarantee them that. So migraine headaches should not be treated with narcotics. Kidney stones, and granted, if someone has a kidney stone, we do treat them with narcotics. Who's had a kidney stone here? Okay. Any men? No men, because that's the most painful thing a male will ever experience, is a kidney stone. How about you? Is it, anybody agree? This is one of the most painful things. You know, they come in kind of with a kidney stone shuffle, and they're, you know, dancing around. You know, when that happens, we treat them immediately. We've done a good job. When I first started in practice 25 years ago, we had to do a tomogram, which was with dye, and you know, it actually took like 4 hours. And then all these drug seekers were all allergic to dye, so you couldn't study them. But now we do a CT. The CT scanners in the emergency department. So if someone does have a kidney stone, boom. I mean, they're in and out. I had a guy yesterday. Within 15 minutes, I had him kind of in-out pain control and had the diagnosis of a kidney stone. So that's really changed our practice. I always tell the story of it was actually a chiropractor's wife who had a drug problem. She kept coming in. This was early on in my practice. And blood in the urine is also a sign of kidney stone. And I think she was allergic, so we kind of always had to base it on that. Her urine comes back and it's full of blood. And I walk in and I don't believe her. And I grab a hold of her, and I grab a hold of her right hand, and I start squeezing her fingers. And there was a pinprick on her pinky, and blood starts coming out. And what these people were doing, where they prick their finger, they pee on their finger, a bunch of blood in the urine, and they were allergic, so we had no other modality, so we'd have to, we would treat them. So I certainly caught that person. So kidney stone, we're not seeing as many people coming in with kidney stones because they know that they're going to have a CT scan. Neck pain, generally there's a bunch of other therapeutic modalities. If someone truly has acute neck pain, short-term with narcotics, I only prescribe 12 Vicodin, Percocet at a time. That also comes back from a medical legal background. If you're not better in 2 to 3 days, you need to be reevaluated. I always tell this story. This was 2-3 years ago. It was it was the Friday before Memorial Day. And I know lots of ER docs, and a friend of mine from Portage called me. He said, Wojciehoski, he said, this is just weird. And I saw this guy from Milwaukee. He's going up to Minocqua or whatever. I can just see that his next stop is going to be your emergency department. And he said, I kind of got duped. I gave him a few Vicodin. And he said, but just watch out for this guy. So, 45 minutes later, comes in, 3 kids in tow, his wife going up to the cottage. Okay, so he's from Milwaukee, he's from West Dallas. I put the wife and family out. I actually called the drug detectives because I think I know where this is going. So I go in and introduce myself. I hear, oh, doc, you're not going to believe it. Left, West Dallas. I've had this neck problem. I haven't seen anybody in 6 months. I didn't, I used to take Vicodin, VIC, O-D-I-N, Vicodin. You heard of it, doc? Yeah, I'm just a country doc. Yep, okay, I've got the drug detectives. Have you ever seen anybody before this? Well, it's been, it's probably been a year. My doc called something in a year ago. Have you had any medical treatment recently for this? No. Have you been in any emergency department? Oh, no. It's the holiday, and, can you help me out? Can you give me some Vicodin? 30 would be good. That'll get me through the weekend. And so, the guys just lie. I go, you know what? I looked at him, I said, you know what? You're bullshitting me. And I pulled the curtain back, and the 2 drug detectives were there. It was 4 o'clock in the afternoon. It's a felony. They put the guy in handcuffs, and then we kind of do this. We take him through the waiting room, all right? like this. Everybody's looking, it's packed, it's Memorial Day weekend. And they take him, and since it's a felony, it has to be heard. Well, 4 o'clock on a Friday, there's no judge around before Memorial Day. So, unfortunately, I mean, sad situation. The guy sat in jail until Tuesday, and his wife and children sitting there in the waiting room. But, you know, he was scamming us. I researched him then. I researched his doctor. I reported his doctor to the DEA. His doctor was investigated. His doctor was prescribing something like 600 Tylox at the time a month. 600. I mean, it's just nuts. It's absolutely nuts. Which reminds me, we had a city councilman. This lady was OCD. She was nuts. She had all these pain things. She was coming in. It was the craziest damn thing ever. When we finally, they did a garbage search and everything. When they finally got the search warrant, her basement was a drug warehouse. She had 18,000 injections of Imitrex categorized. She had something, I think there was something like 70,000 pills, narcotics, and she was using this stuff. She had, it was a whole warehouse in her basement. And you know the crazy thing? She had seen, I think it was, if I remember correctly, the insurance report, she had seen 87 different providers around the state. And the real crazy thing is insurance was paying for it all. Thousands and thousands of dollars. And never really figured out, you know, she was using it and abusing it, whether or not she was selling it, but it was just, it was absolutely nuts. That was one of the cases that was earlier on in my career. Back pain, we've certainly talked about, you know, the appropriate modalities. Toothache, we've changed our practice in toothache. I'm very adept. These are meth mouth, from, you know, methamphetamines, and you'll see the progression of these people. You know, people come in with a toothache, and you know, before we didn't do too much, but I'm pretty adept at dental blocks. We use long-term anesthetics. You know, we refer them, so people aren't coming in as much, you know, seeking. You know, dental blocks. Always the interesting thing is these people have, you know, they may have fairly good-looking teeth. They've got a toothache. They're full body tattoos, body piercings. They say, well, I'm going to inject you. You know, I'm going to numb your mouth up. I'm going to get you over to dental. Oh, doc, I can't stand needles. I'm going, how did you get all those tattoos and that piercing in your tongue? You know, how did you do that? Oh, I'm afraid of needles. I guess, you know, I'll just toughen it out. You know, I can give me a narcotic. So. We've done a good job at that, at, you know, trying to circumvent some of this prescription drug fraud. I think it's important that you identify these people. You know, we've always thought, I mean, probably 10 years ago, I think when I was chairman, I stood to, you know, the registration folks. I said, you need to identify these people. I mean, find out who these people are. All these people come in without IDs, and they're, you know, they're asking for narcotics, and you're providing all this treatment. And I was thinking, this gal, she came in, her name was Yolanda Jones. And she comes in, and she's a light-skinned African-American, maybe Hispanic, like Puerto Rican, comes in with an address of 1234 Main Street, Stevens Point, Wisconsin, no ID. And then she's telling me all these doctors she's seeing in Wausau. She'd been living in Stevens Point. And she was seeking hydromorphone, writing it out, because she had sickle cell crisis. And, you know, in our area, it's unusual. So I called up to Wausau and talked to a few different people, and I go, well, not Yolanda Jones, but it's Yolanda, it was a Hispanic name. And I said, well, what's her date of birth? It was the same thing as Yolanda Jones. I said, how about her social security number? Same thing as Yolanda Jones. So I go back and have the drug officers there. I go, Yolanda, you're not going to believe it, but I've uncovered something terrible. There is identity fraud going on in Wausau, and there is a woman in Wausau who is misrepresenting herself as you. I said, how does that happen? I don't know. Can I have my hydromorphone? No, you know. So we kind of, and it took probably 30 minutes before she finally confessed that she was there under false pretenses. But it takes some investigation. You do need to identify that. You know, and in a busy emergency department, it's easier just to write the prescription and get them out. You know, I take the time because it's a passion of mine, and I won't, you know, I just don't allow it to happen. out-of-town patients, multiple drug allergies. I'm always suspect of out-of-town patients, I had a guy who came, he literally, talk about bad luck, I happened to be working a night shift. He fell down the steps while helping remodel his daughter, or his sister's apartment. And I think the guy's from, I think he was from down, I think it was Manitowoc or something, and it didn't make a lot of sense. And I started to research this guy, this is the honest to God truth, almost 2 years to the day, he had been in the emergency department with the same complaint at like 2 in the morning because he fell down the stairs helping remodel his sister's apartment. And it ended up, I confronted him, the drug officers, the police cars were coming, he had parked in the ramp, they blocked him in, he went running out. This was a crazy, this terrible back pain that he had. You should see these people with terrible back pain when the police are there. They can run faster than anybody. So they go through his car. He's got hundreds and hundreds of prescriptions. He's there with a girlfriend as well. And they had started in Manitowoc. They were seen in Manitowoc, Sheboygan. They came all the way up. They were here in Appleton, Fox Valley, Green Bay, New London, Wapaka. And they started 6, 7 at night. And they had prescriptions, just tons of prescriptions. They were going to sell them. They scan them. They scan doctors' signatures. Big business. And he was certainly arrested. But I'm always a little suspect of the out-of-town patients with some of these unusual complaints. So disclosures, you have to have disclosures. Security Health has been certainly good with us. We get letters saying, do you realize this person has seen 7 different providers in the past week and received, narcotic pain medications. So warning signs, patients are taking the medications that they're not taking them as prescribed. They always have to worry about that. Multiple prescriptions from multiple doctors. Many times there's comorbidities, there's psychological issues, there's alcohol abuse, there's other issues that need to be looked at. Many times we see people, I think I know at Employer Solutions, patients or people have called many times anonymously, or family members have called and said, this just isn't quite legitimate. I don't believe, I'm concerned about, my brother, my sister, whomever, they're seeking narcotics. They do have, trouble, and please be aware of it. So, as I wind down, I think it's important that we practice evidence-based medicine. I think it's important that we remember that back pain resolves in due time, unless there's a significant malady. NSAIDs are important. Narcotics in short term, important. Okay? Physical therapy plays a role. Surgery rarely is necessary. I think recovery can involve a multifactorial, multidisciplinary approach to getting people back to the workplace. Once again, evidence-based treatment is essential, whether you're seeking someone for your own personal care or for a work-related injury. Very, very important. Narcotic treatment must certainly be monitored. So on that note, since I talked about Italy, an Italian father was talking to his son just before the wedding. He said, son, he said, for your wedding, I'm going to buy you a gun. Well, Dad, I don't need a gun. A nice Rolex, a nice watch. He said, son, in our family, it's a tradition. The grandfather got married, got a gun. I got married, got a gun. You going to get a gun. He said, Dad, I'm kind of a pacifist. I have no use for a gun. A watch, please. Son, tradition in our family. Dad, you're not listening. Son, you're not listening to me. He said, what are you going to do? 6 months after you're married, you come home early. You walk in, you say, honey, I'm home. No response. You walk upstairs. There in your bed is your wife with your best friend. What are you going to do? Say, time's up. And on that note, time is up. I appreciate you having me here. I'm happy to entertain any questions. If there are any, I'll be around for a while. If you want to talk to me personally about something, happy to do it. But other than that, I have nothing else. Okay. Oh, yes?
For the treatment of the migraines, the coauthored?
The treatment of migraines.
Migraines, yes. Is that IMPO? How are you doing that?
Well, when they come to the emergency department, I probably could get by with doing PO stuff. But I really like, I used to use droperidol, but it's gone out of production. So I do use Phenergan and I do use Zofran. A lot of these people do have some nausea and vomiting. You know, truthfully, the efficacy is probably the same in the oral stuff. It may take just a little longer. But in the emergency department, because we're so busy, our volume is 44,000 patients. And so we're really busy. And we've got them lined up. So, I mean, we bring them in, put an IV in. I give them, I had 2 migraines yesterday. Both of them I started with Phenergan. It's kind of sedating, gave them some oxygen, high flow oxygen, Decadron. There's been some studies that say that prevents the rebound. And the other person I gave some Zofran to. And Reglan is another medication that works. Reglan has a little higher dystonic effect, so people can get some weird muscle stuff, some side effects. So,
you mentioned the Thorazine.
Okay.
Is that PO or IV?
No, Thorazine I use IV. And you have to do it IV because efficacy is good. Plus, you have to hydrate these people because it can cause hypotension. And so you give them a liter of fluid, give them 12.5 milligrams of IV Thorazine, and that's after, after the, if the Phenergan doesn't work. I will try some IV Toradol, which is, it's a non-steroidal, it's like ibuprofen. So.
Are you with the anticholinergic effect? Do you give anything anticholinergic?
No, I don't. I mean, when these people, when we do see the dystonic stuff, I don't pre-medicate them with Cogentin or with Benadryl. But if people start feeling a little agitated, I usually just give them 50 milligrams of IV Benadryl.
Thank you.
Sure. Any other? Oh, yes.
I'm a physical therapist.
Okay.
And obviously talking about the medications, that's a little bit, most of the time when I talk about referring to physicians, I say that this isn't my, I know generally now. For reference, like you gave us a lot of good references, as far as medications. Where would you suggest, or how would you suggest we handle that? Can I refer, I can say, well, Dr. Bojo told me.
Yeah, that's right. It's gospel. Take my book. It says it in here.
But I find it, sometimes we'll run across that, and then people ask questions like that. For us, as far as reference, obviously, we'll have this
Sure.
PowerPoint.
Yeah.
How would you suggest what would be a good reference?
Okay.
Because I want to kind of take the...
Yeah, the evidence-based practice. And the question, for those of you that didn't hear it, this gentleman's a physical therapist, and, how do you address the issues of narcotics with your patients?
Right.
And what kind of references? I personally use something that's called Up to Date, okay? That's a physician peer-reviewed website that reviews, I think, 500 journals, 300 textbooks. This talk I actually developed out of the article on treatment of back pain. Unfortunately, it's a subscription site. It's like $300 a year. So if you have access to that, there is something, there's a new site that we're starting to use at Ministry that I just looked at. It's clinicalkey.com. I think that's isn't it, Luann? Is it clinicalkey.com?
Yeah.
Okay. You could look at that. Cochrane, C-O-C-H, I think A-R-A-N-E, the Cochrane reviews, that's always very good. PubMed is good. And what I do and what I've done in the past is, with Up to Date, I will, pull those articles up and keep them as a PDF file. Sometimes if I need to refer them. And you can always get in touch with me, and I'm always happy to help you with that. And I know it's a touchy situation. Physicians, providers, mid-level providers, they don't like to be challenged sometimes. And I'll tell you, people get really nervous, especially in these narcotics cases. They say, help me understand how this person needs 120 Tylox, every 2 weeks. Do you think that's in their best interest? When you start talking narcotics, and if you start questioning someone's prescribing practices, if someone called me up and said, why did you prescribe 12 Vicodin? I'd be, I hope I'm not going to hear from the DEA about that. Because it's a worry. You can lose your license. This guy in West Dallas lost his license. Yes?
Who do you feel, or do you have much opportunity to have that addiction counseling conversation with people that come and looking for drugs that you feel are the users versus the sellers?
Yeah, with the users, and I always hate when the speakers say, I had an unfortunate case yesterday. Someone that I know used to work for us, was diverting medications. maybe fell off the wagon, I don't know. But it's, you have to, I do confront the people in the emergency department. In some of the patients that I see in occupational medicine, I personally will confront them and say, this just isn't good medical practice. And it's always, it's difficult in the emergency department because a lot of these people you don't know. I'm many times in a different situation just because I grew up there. I was born in that hospital. So there are people that I can address that with and say, this isn't in your best interest. Sometimes people do seek it out. We do have, our psychiatrists, I think a couple of psychiatrists are addictionologists, so they do some of that. We do make a referral, but, you can only help those that want to be helped. Yes?
We recently had a workman's comp where the doctor was suspicious and actually had the employee sign a drug contract.
Sure.
Are you seeing the use of that?
Yeah, I think there's some merit to that. It certainly helps me out. All pain, is my opinion, all pain management has to have a drug contract, okay? One patient, one provider, okay? Very important. We do that in the emergency department in some of these, these patients who do have chronic pain. So one provider, one patient. Everything needs to be monitored through the primary care provider who's ever doing the pain management. They do need to do, and I'm asked about this in my medical legal practice and many times calling people, they do need to do drug testing on them to see if they're taking them. And they need to be, random drug screens. So, because it's to see if they're taking them or they're diverting them. In the work comp arena, if it's truly a work comp injury, it's one thing, and they've got a severe injury, it's one thing. But, a lot of these nebulous complaints, why not? You get 120 Vicodin, and it's free, and I'm selling for $10. Good money. So, there is some merit in the drug contract. It does, it gives the physician, the treating physician, the opportunity to dismiss them, say, listen, that stuff is out there. It's very good for me. It's documented in the medical records. We have, our medical record system is Cattails, which is Marshfield Clinic. It's the repository for ministry records. We also have access to the Aspirus records. So if you find that, people will come in, with these pain complaints. Maybe you don't know, you look at the records, you see there's issues. You go back and say, are you under pain contract? Well, yeah, I guess so. Okay, it makes it very easy for me. I can't help you. I'll treat your pain with a non-steroidal, okay? I will try to make you comfortable, but no narcotics. And legitimate people say, I respect that, I understand that. The other people say, well, I'm just gonna go elsewhere. Have a good trip. Yes?
You found starting to see Botox injections for myofascial pain.
Right. Question is about Botox. I mentioned it earlier. The early research, I have to tell you, I haven't in the past 2 to 3 months, I haven't read anything recently on Botox, but I think the studies are positive out there. Plus, these people look really good. They look very young after the Botox injections. But it does, I think there is some merit to it in treating, myofascial pain, some, mechanical low back pain, you've got muscle spasm. So I do think, and now that you've mentioned, I'm probably going to research the literature and see if there's anything current out there. Any other questions? Yes?
I had a gentleman from work the other day ask me something. He had a herniated disc a few years ago.
Okay.
And had corticosteroids into that disc area.
Mm-hmm.
He's been doing fairly well in therapy and stuff, but now he's getting more numbness and tingling in his feet and toes.
Okay.
I wanted to know if this should just be something that was going to be ongoing, or should go back to his doctor. Is it going to cause damage?
So the question is, someone has had disc herniation, they've had an epidural, now they've got some peripheral neuropathy, some unusual, some numbness and tingling in the feet. I guess the real question is this bilateral? Okay, so is there an underlying medical problem, such as diabetes, some sort of cause of peripheral neuropathy, alcoholism? Those are things that would need to be investigated. investigated vitamin B12 deficiency. So is it that, or is it indeed a disc herniation that is causing some, neurologic finding? I think it needs to be further investigated, especially if it's a disc herniation causing bilateral, neurologic symptoms. They may need intervention. Surgical intervention, and surgical intervention is clinically indicated with the, neurologic findings, loss of reflexes, weakness, foot drop, paresthesias, chronic intractable pain. I mean, if you can correlate, that's the one thing about neurology, is you can correlate, where the lesion is, it's going to make sense because it's all electrical pathways. So I would, from what you're telling me, most likely they need further evaluation. Any other questions? Yes?
Kind of a follow-up.
Sure.
Question, sorry. Now, you gave me some great websites and things to go to. But for the average person, if I'm going to relate this to a patient, to somebody, for the average person that's going to, basically, we're going to need to go to the site and kind of do some interpretation about what to give them, right?
Sure.
They don't have a place themselves really to go and check it out.
No, yeah,
I'm just wondering.
Yeah. The question is, with the layperson, where can they check it out? WebMD is reasonable. I think Mayo Clinic. So it's a peer-reviewed.
Okay.
I think it's always, you have to be very careful if you're going to, some sole practitioner's website that has, some crazy stuff out there. So peer review, like I said, I think, Mayo Clinic, I think is it .com or .edu, or, WebMD. At least it gives them some place to look that's, somewhat peer reviewed.
Because the reason I'm asking that is, I kind of want to teach them how to fish.
Sure.
Rather than give the fish.
That's, sure.
So if I just teach them to do
Right.
that,
Yeah.
it kind of takes a little bit of the, liability to each
Yeah.
hand.
Well, yeah, and that's very reasonable. Plus, it gives them ammunition when they come to see me. They go, "I read on the internet." So if it's there. Anything else? Well, once again, thank you. If you want a book and didn't get one, let Melissa know, and I can get her a box. I do appreciate it. It's really been an honor to speak with you today. Thanks for having me. And work excuses for everybody. Take the day off. It's going to be a great day. I'll be at the table signing them for you.